Hey everybody, I'm just going to start sharing my screen. Okay, so I wanted to start by saying how sad I am not to be joining you in person. I was really looking forward to coming to Ghana, learning more about your country, meeting you, sharing experiences, sharing stories about our lives as nurses, and looking at how we can support each other in some of the challenges that we face. So my name's Vanessa Heaslip. I'm a Professor of Nursing and Healthcare Equity at the University of Salford and also a visiting Professor at the University of Stavanger in Norway. And so today, really, I want to share with you some of my work and my experiences when working with people who find themselves socially excluded, discriminated or marginalised. This has had massive implications across their lives and that of their families. During this keynote, I want to examine some of the challenges people can face in accessing healthcare and the health inequities they face. But along the way, I shall share my experiences of working with individuals and communities and will offer insights into how we can all work in more socially inclusive ways. Before I go any further to explore the experiences of those who experience health inequity, those that are socially excluded, I think we need to consider some of the international policies in which we work. And what you can see here is the United Nations Sustainable Development Goals. And I'm sure many of you will be familiar with these. And whilst there have been critiques linked to their simplicity and the perpetuism of colonialism, they are an attempt to globally unite efforts to address issues related to health, well-being and prosperity for all. And it is the for all part that I am most interested in. So if we think about the context of healthcare and we think about our roles as nurses, then many of the Sustainable Development Goals are fundamental to our professional practice. So if we take, for instance, no poverty, number 1, zero hunger, number 2, good health and well-being, number 3, quality education, number 4, gender equality, number 5, clean water and sanitation, number 6, decent work and economic growth, number 8, and reduced inequalities, number 10, just to mention a few. Yet what we do know that there was a review of progress of the SDGs by the United Nations in 2022. And in this review, it demonstrated that many of them have in fact shown a deterioration in progress in areas particularly such as poverty, food security, immunisation coverage and employment due to a variety of factors, including the long-term impact of the COVID-19 pandemic, climate change and conflict. And so I think it's evident there is much more that we need to do. I believe that nurses are fundamental to helping us meet the Sustainable Development Goals. Yet it is interesting the degree to which they feel connected and empowered by these. There was a scoping review undertaken by Fields et al. In 2021. They looked at 35 papers and they noted in this review that many individual nurses feel disconnected from the Sustainable Development Goals and struggle to relate these to their clinical role. I believe that as nurses, every single part of our work as nurses is linked to the Sustainable Development Goal. That as part of our holistic assessment, when we look at the whole entire experiences that affect an individual, we've got to be considering things like their work, their poverty, the quality of their accommodation, whether they have access to clean water and sanitation. And if we don't look at some of these fundamental wider social determinants of health, how can we work with people to improve their health and well-being? So herein comes my first call to action. I believe there needs to be much more targeted research to better understand the challenges that face nurses, aligning their professional practice to the Sustainable Development Goals. And then nurses need more education about how they can use these goals and how they can contribute towards meeting these goals within their daily lives. As part of this is better educational preparation, and that includes a stronger awareness of global policies as well as a stronger development for nurses in developing their advocacy skills, so they feel better equipped to identify and design services which are much more inclusive. And I want to go on and talk a bit more about some of these wider social determinants of health. And I really want to focus on the impact of poverty. Poverty is the single largest determinant of health. But frankly, poorer people have shorter lives and greater health and well-being challenges. In respect of their social outcomes, the impact of poverty has a negative impact on education and attainment, family functioning, abuse, crime, and these are well documented. What we also know is that there is a generational impact of poverty. So a family born in poverty are much more likely to have their children growing up in poverty. And that's because of those wider issues around education and attainment, quality of their accommodation, their family functioning, etc. And so whilst I think we have to consider poverty between countries, we can't afford to ignore poverty within countries. We know that the COVID-19 pandemic had a disproportionate impact on the most disadvantaged groups in societies, and that the repercussions of this are still being felt, as the gap in levels of well-being between high and low incomes has increased by 50%. In addition to poverty, there are other factors that influence health and equity, and these include gender, ethnicity, disability, sex, caste, or belonging to another socially excluded groups. But we also have to recognise that many of those individuals in those wider groups will also be living in poverty. And that's because of the intersecting nature between the discrimination that people can experience that has a negative impact upon their life chances across their life course. So Michael Marmara argues that there is a social gradient of health. That is, the lower an individual's social position in society, then the worse their health experience or their outcomes. Conversely, the higher their social position, the better their health. He asserted that policy actions should focus on addressing this health social determinant, calling for multi-agency approaches in recognising these wider social determinants of health. And I see that's a key role for us as nurses, working interprofessionally with other groups to address some of the wider social factors that have a negative impact upon an individual's physical or mental health and well-being. And I want to explore this a little bit further. So I was lucky enough this year to have been asked to participate in the World Health Organization European Regional High-Level Forum on Health and the Wellbeing Economy. And here you can see a pictorial representation of health and well-being. They note that well-being includes the ability of individuals and society to thrive, including aspects such as their sense of belonging and mattering, their social cohesion, in addition to some of the more direct measures of health status that assess both their physical and their mental health. So in order to achieve this well-being, they note that there are 4 dimensions. Those are human well-being, social well-being, economic well-being, and planetary well-being. And these 4 dimensions are vital to achieving both inclusive and sustainable development, as together they promote trust, social cohesion, and participation. This in turn promotes equity, enabling both healthier, fairer, and more prosperous societies where people can thrive. It is important here to recognise that the economic dimension does not really concern the neoliberal promotion of acquisition or capacity to be rich, but rather relates to the equitable distribution of resources at global, national, and community levels. So let's take a moment to consider these further. The links between health and human well-being is undeniable. It covers not only life expectancy, but also issues such as mental well-being and our ability to carry out normal day-to-day activities free from illness. But it also includes both quality and non-discriminatory health and social care, policies for housing, food and fuel security. And we know that many people who are socially excluded, sadly, do experience discriminatory practices from nurses and other health professionals. and we need to begin to address this. The issues around human health and well-being are also really important, as people in many countries are struggling due to significant cost of living increases, which include the cost of fuel and food, leading to increased inflation rates. I was watching the news the other day in the UK, and they were saying that every 8 minutes a young family is made homeless. So that's women, fathers, and children having to live in temporary accommodations like bed and breakfast accommodation because they can't afford to pay their rent. If we look across the European Union, inflation has increased, leading to 2% higher levels of deprivation and a 5% higher level of absolute poverty since 2021. If we think about social well-being, and this includes living free from the threat of violence, a sense of belonging, and social cohesion. Yet sadly, every 11 minutes, a woman or girl is killed in their home. And we know when we look at health exclusion that women are significantly more affected than men. And this really brings into importance the gendered aspect of the Sustainable Development Goals. So we can argue that the links to these first two domains are really easy for all to see. But what about the others? Economic well-being is about having a living wage, gender-responsive employment, universal social protection throughout the life course. And we know that these social determinants of health, that these aspects have a major impact upon both health and societal connection throughout people's lives. Just now I mentioned about the devastating impact of poverty on health and well-being. Lastly is planetary well-being, including a stable climate and biodiversity. Over the summer, there have been massive widespread fires across Europe, and these really have highlighted the devastating impact that global warming is having on the planet, but also for the people who live there. Not only were significant lives lost, but people lost their homes, their livelihoods, and this will have a devastating impact for years to come. But also within this planetary well-being, we have to consider the effect of zoonotic infection. Zoonotic infections is a transmission from animal to human infections. Because of things like deforestation, urbanization, tourism, wildlife exploitation, and climate change, we've seen an increase in the number of zoonotic diseases, the most recent being the COVID-19 pandemic. So connections between these dimensions are vital in terms of co-benefits and conversely co-costs. For example, if we consider a living wage, this can have benefits for health and well-being. Health and sustainable living environment within the planetary well-being, but also a sense of belonging and cohesion within our social well-being. Likewise, any negative impacts in one sector leads to additional costs in another. Yet, how much consideration is there in policies of practice regarding economies of well-being? And I argue that embedding this is fundamental. This slide has been widely used to demonstrate the difference between equality and equity. And as you can see from the first slide, there is nothing more unequal than the equal treatment of unequal people. So in the first picture, you see the equal treatment. Everybody's given the box the same size. But you also see in the first picture that not everybody is equal. People have different needs. And so a focus on equality, i.e. treating everybody the same, can actually perpetuate inequity, which is about an unfair treatment. Yet much health policy, both nationally within the UK, but also internationally, focuses on equality. And I think that we need to go further. I think we need to go towards moving towards the right, where you see the mesh in the third image. And that's where we really start to address systemic barriers that impact upon people's ability to both live healthy and happy lives, but also to access the support that they need when their health is poor. If we think about social exclusion, there isn't any universally agreed definition or benchmarks, but lack of participation in society is at the heart of nearly all definitions. Overall, social exclusion describes a state in which individuals are unable to participate fully in economic, social, political, and cultural life, as well as the process leading to and sustaining such a state. People in groups who experience social exclusion is as wide as social exclusion occurs based on many different attributes, and many of these you can see around the outside of the circle, such as age, sex, gender, disability, race, ethnicity, religion, migration, socioeconomic status, place of residence, and sexual orientation. And if we think about social inclusion, it is about the process of improving the terms of participation for people in society through enhanced opportunities, access to resources, voice, and respect for rights. And it's no surprise if we look at the health outcomes of different people within the groups that are provided around the outside of the circle. Many of them have poorer health outcomes. So for me, a call for us as nurses is to critically explore the impact of both policies and practice and how much of that actually focuses on equality rather than addressing some of the systematic barriers that these individuals can face. I think because of the massive transformation that's really happened within the digital technology and the growth of digital technology in healthcare services, we've really got to consider the impact of digital exclusion. So contemporary health and social care has seen a massive growth in genomics, artificial intelligence, digital and telemedicine, and robotics, all of which are promoted to give more access and effective personal care for patients. This growth in digitalisation has led Kit Bush and colleagues to argue that digital transformation has to be considered as a new determinant of health, due to the significant impact that digital technology has across the life course. There are three main contributors to digital exclusion affecting society, and these are social exclusion, low income, avoidance, lack of motivation and commitment, and disability. A digital exclusion, which includes a lack of hardware devices and internet services. And then lastly, accessibility, which includes Wi-Fi connectivity between rural and urban areas and the differences in digital and information literacy. And I wonder how many of you as nurses are involved in any sort of digital transformation you're having in your services. You know the communities with which you work. You know some of the challenges they may face, but actually, do you have a seat at the table when it comes to development of digital innovation? And I argue that as nurses, we need to become much more involved in both the development, the design, and the evaluation of digital services to ensure that they are inclusive rather than exclusive. We know that other factors are also relevant, such as age. Older people are much more likely to be digitally excluded. We know that the gender divide is impactful here, in that digital divide negatively affects women. The lower your educational attainment is strongly associated with non-internet use. And yet economic disadvantage is probably one of the strongest determinants of digital disengagement. So we as nurses, I believe, have to address the degree to which inclusive digital practices are driving digital developments, or we risk leaving people behind. The health impact of social exclusion is enormous. There was a large systematic review and a meta-analysis of 337 studies, and this identified that when age was considered, socially excluded men's mortality rate was 8 times higher. Socially excluded women's mortality rate was 12 times higher. Death rates from infectious and parasitic diseases was 3 times higher in socially excluded men, almost 6 times higher in socially excluded women. Deaths due to poisoning, injury, and other external causes, 8 times higher in socially excluded men and nearly 19 times higher in socially excluded women. Lastly, the prevalence of death from cardiovascular disease, respiratory disease, cancer, and asthma was also significantly increased in socially excluded groups, with the risk consistently being higher in women than in men. As I've noted, people are often socially excluded because of their position in society, which constructs and places lower value on them, resulting in them being at a disadvantage. In terms of our professional practice, we need to be aware that some of our patients may hold differing worldviews than ourselves. Our worldviews are really a system of knowledge that develops from birth and is shaped by cultural, social, and the physical environment in which we grow up. It is shaped by our culture, the experiences we have, and the belief systems we encounter. Yet many people will not be able to articulate their worldview. However, it is evident that commonly agreed beliefs and practices held by people and our own personal worldview will influence how we think, what we know, and how we carry out our practice. For example, if we think about healthcare systems in the global north, we typically tend to focus not on health, but actually illness and disease. And this is underpinned by a mind-body duality and the scientific assumptions related to objectivity, measurement, and reductionism. Therefore, any sort of nursing interventions and healthcare interventions are aimed at problem solving and treatment, trying to restore the body back to what it was before, if you like, the normal. Yet we rarely critique this worldview, which can lead to biased interactions with patients who may have opposing worldviews. Yet when this happens, rather than listening to their perspective, their beliefs, their values, rather, we tend to hold them responsible for not adhering to treatments or other interventions. We label them difficult, non-compliant, non-concordant, rather than considering that actually it may be our care plans that may lack relevance and have little meaning because they cannot be reconciled with the patient's health beliefs, practices, and their everyday realities. It is important to note that our worldviews will influence our research and our research practices, but also our professional practice. So as a nurse academic, I review lots of papers. I work with students. I work with students undergraduate, but also doctoral, postdoctoral. And it is amazing in my role as an associate editor, how often I review papers where people talk about clients that are hard to reach, hard to engage, difficult to access. And these typically are people that are socially excluded. And yet I wonder, using such words such as hard to reach, hard to engage, what's the underpinning message that we are giving? And often it's that we're laying the blame at those individuals. It's their fault that they are difficult to reach. It is their fault they are difficult to access. Rather than perhaps considering that we may need to adapt our services to work in ways that are much more embracing, culturally sensitive, enabling people who find it difficult to access healthcare to come and talk to us and to access our services. So what it doesn't do is challenge these worldviews that we have about our service, that everybody needs to come to us. So within the UK, we're moving towards a recognition that there are actually no hard to reach groups. Rather, there are simply underserved groups. And you may think about that change in terminology from hard to reach to underserved. Underserved really focuses the responsibility on us as professionals to serve, to reach, and to work with these groups, rather than the emphasis being on them to work for us. So one of my calls to action for you is to think about and to challenge language which is not embracing of individuals from socially excluded groups. Challenge language that perpetuates the exclusion of those that are already excluded, but also challenge maybe some of the structural barriers that make it really difficult for people to engage. So perhaps consider, do you ever review your services? Do you ever ask some of your patients who may be socially excluded how easy it is to access you, to access your services and some of the challenges they face? I believe that as nurses, listening to the people that we're working with enables us to develop services which are much more inclusive of people's needs. key aspect of that is about professional practice, and that is about the proprietary education of the registrants. So this is from a paper that I did where I led a study exploring student nurses' understanding and knowledge of working with Gypsy Roma travellers from across 4 universities in Belgium, Turkey, Spain and the UK. And the findings from this study identified that actually whilst the majority of the students had little formal professional experience of working with Gypsy Roma travellers, they had very clear ideas and perceptions regarding them. And some of those perceptions reflected cultural norms such as nomadism and the family-centred community. But there were also some really negative perceptions that influenced their professional practice. The participants entered their proprietary programs with either direct or indirect exposure, and that's the first box that you can see. And this is perpetuated through their on-course exposure, which subsequently influenced their professional practice. And whilst the study I've presented here focuses on Gypsy Roma travellers, the model presented, I believe, could link to any socially excluded groups. So whilst we can't influence students' pre-course exposure, as educators, we do have the opportunity through both theoretical and practice course exposure to challenge and explore students' previous and current experiences and perceptions. Nursing is a values-based profession, and as such, I argue that educational approaches have to consider values as part of the curriculum. And part of this is the opportunity to explore and challenge stereotypes and prejudices in a positive but a safe environment. Using the principles of transformational theory led by Mesereau, we as educators can embed curricula which highlights both habits of mind and points of view. Within this exploration of habits of mind, students need to be encouraged to reflect critically upon their habitual ways of thinking, feeling, and acting, examining how these may have been influenced by cultural, social, educational, and political perspectives, which they then articulate in their specific points of views, their beliefs, their values, their judgments, and their attitudes. McAllister argues to the value of transformative learning in its ability to awakening students the issues of injustice that lead to and both sustain health inequities, and to promote in students both the critical thinking and the questioning of previously held assumptions, beliefs, values, and perspectives, so that they in turn might be part of systemic change. It is in this systemic change that I argue that nurses will be able to begin to address health inequities to enable a more just and equal society. My penultimate slide is really talking about some attributes that when you're working with or even researching with those that are socially excluded. And these include curiosity. It is about a respectful, questioning approach. It is about a willingness to suspend one's worldviews to enter the world of the other, what's important to them. And once I understand that, I can work with people in a much more respectful way. It is about compassion. It's about respect for the dignity and the selfhood of others. I believe as nurses, we need a commitment to social justice, to economic justice, and that's about being reflexive in our practice, challenging language, challenging processes that actually do not promote social justice. And lastly, about co-production. That's about being able to work outside the box in different novel ways with people who often don't have a voice, to understand their experiences, but also in the development of new services. I want to finish with a variety of calls to action. And this is for you to critically reflect on the way in which you work as a nurse and explore ways in which your practice could be more inclusive. I want you to consider, actually, how much do you use the United Nations Sustainable Development Goals in your practice? How much do you consider these? Is there more work that you could be doing to help us as a community, as nations, meet the requirements of the UN Sustainable Development Goals. If you're a nurse educator or you lead nurse educational programs, actually consider having a stronger focus in your programs, both on global policies, but also building advocacy skills within nurse registrants, either as student nurses or as registered nurses in continuing professional development programs. How much do you align your professional practice towards wellbeing economies? How much do you consider the wider social, environmental, financial well-being, as well as the human well-being? I want you to think about the policies where you work and how much those policies focus on equality rather than addressing some of the systemic barriers. Should we stop using the word equality and now focus on health disparities, health equity? I really want you to consider the degree to which digital innovation is developing and enhancing your practice, but also to take this from a critical stance. How inclusive is those digital developments, or will they perpetuate further exclusion in those that are already excluded? I want you to think about and I want you to challenge any language which perpetuates exclusion and think about more inclusive terms. Think about how we prepare our students, both in universities, but also when they're with us in clinical practice. How much do we give space? How much do we encourage students to critically reflect upon what they think, what they feel, and how they act in a way that's safe and secure, that enables them to critique and challenge what it is that they think that they know? Lastly, I want you to consider ways in which your practice or research, if you're a researcher, could be more inclusive. I want to finish by thanking you for taking the time to listen to my thoughts. As I noted, I'm really sorry not to be with you in person. Sadly, I caught COVID at the end of last week, which meant I was unable to travel. But I have included my email here, and I'm happy for any of you to contact me to continue our conversation. Thank you.